The decision to start treatment for a patient with CLL is still based on determining that that patient has symptoms, or complications, or marrow dysfunction that is due to the CLL and outweighs the risks of treatment. Although there are many very promising treatments that have improved the therapeutic index, there still are not studies that conclusively show that starting treatment earlier in the course of a patient's CLL changes the course of disease or is warranted. So still the same guidelines apply that were established by the international working groups, and those are the ones I still follow today. Of course, there are trials that are ongoing to evaluate earlier initiation of drugs like ibrutinib, and certainly I await those findings. But for most patients, I still want to make sure that that patient is going to have benefit beyond kind of theoretical benefit to their disease. The main first-line treatment options available now still broadly fall into the class of chemoimmunotherapy regimens or ibrutinib. For younger or fit patients or patients that prioritize a treatment that has a defined treatment duration, chemoimmunotherapy combinations such as FCR or BR, or some regimens that now incorporate obinutuzumab, have been shown to have very high response rates and durability of responses that result in treatment-free remissions. Ibrutinib, however, has been shown to be an equally efficacious frontline option, especially for patients who are older, and the duration of remission or the progression-free survival has not yet been reached. It may turn out to be that ibrutinib keeps people well for as long as some of those chemoimmunotherapy regimens. When deciding between different treatment options in the frontline setting, there are a number of factors to consider, and this certainly leads to detailed and important discussions with our patients. Certainly there are some biologic factors that have been established as predictive markers or can predict the quality and duration of response. In particular, it's now been shown that the mutation status of the immunoglobulin gene can predict the duration of remission after FCR therapy, and that patients with a mutated immunoglobulin gene are the ones with a chance of having ultra-long, longer than 10 or longer than 15-year remissions following FCR. Certainly cytogenetics are critical to assess before making a decision, and that patients with deletion 17p will be on the opposite end of that spectrum with very short remissions after FCR. But beyond those factors, certainly patient factors like age and fitness, comorbid conditions are important to take into account. With some of these agents, there are specific factors such as risk of bleeding with ibrutinib or even cardiovascular history, which appears to correlate with cardiovascular complications of ibrutinib. And finally, we should not understate the importance of patient preference. There are patients who are young and fit and on paper would be very appropriate for FCR, but would prefer ibrutinib for with the thought of avoiding potential toxicities, both short and long term. And I don't think that's a wrong choice either. Certainly also in this day and age, we are also confronted sometimes with cost issues, and I think it's also something that we should take into account when helping our patients decide on their treatment.